Thank you all for joining. We will give participants a few more minutes to join and then we will get started. Good morning, good afternoon, good evening, everybody. Thank you for joining Gradient Health Systems sixth webinar in the series, where today we'll be focusing on management of sepsis and septic shock. I'm Miriam Khan. I lead communications for Gradient Health Systems, and we'll be going through a brief introduction before I turn it over to our moderator, Dr. Ndaba. So again, thank you for joining this webinar, again, the sixth in our series of this year. We are hoping to have one more by the end of the year, and I know a lot of you have joined all of them. So appreciate your dedication to these, and thank you for coming back to joining us here. Just before we get started, a few housekeeping notes. If you have any questions during the webinar, please use the Q&A feature to ask us. You can ask while the presenters are speaking. If you have any technical difficulties, that is also where you can let us know if there are any issues. The webinar is being recorded. You will receive a copy of the recording after the webinar in your email. And you can also access this recording as well as previous recordings from our other webinars at our website, gradienthealth.org, under our training page. And then finally, we would love to hear from you. So please do reach out. You must have received an email with the invitation. You can respond right to that, or if you have any questions or feedback, you can email us at customers@gradienthealth.org. I'll now turn it over to our moderator, Dr. Ndaba, to kick us off.
Thank you so much, Mariam. Good afternoon, good morning, good evening, everyone that has logged into this webinar. And thank you so much for finding time to be with us on this interesting topic. So today we'll be discussing a very, very important topic. And this is sepsis and septic shock. I think you all agree with me that this is one of the conditions that's very common, and we've all had to treat a patient with sepsis or septic shock. And so it's important that today we share experiences, try to get clarification on some of the key areas of this topic. So my name is Dr. Ndaba Spuka. I'm a physician anesthetist from Zambia. I'll be your moderator in this session. And then our two presenters, we have Dr. Julian Chomba, who will take us through the first part of the session. Dr. Chomba is a physician anesthetist from Arthur Davison Children's Hospital in Zambia. And then we also have Dr. Masuzio Ziambo, who will take us through the latter part of the session. Dr. Masuzio Ziambo is a physician anesthetist from Levi Mwanawasa University Teaching Hospital in Lusaka, Zambia. So we look forward to an interesting session. At the end of this session, we really want to encourage a fruitful discussion. Ask questions, share your experiences as much as you can, and also let's enjoy the diversity of knowledge from our various countries and institutions. Without much ado, before we introduce our first speaker this afternoon, I'll just take you through the objectives of the session. So at the end of this session today, we expect that we should be able to understand the current definitions related to sepsis. There's been a lot of evolution in terms of the definitions that are related to sepsis. And so we need to understand which definitions are currently being used. Then we'll also describe the epidemiology and also the disease burden in relation to sepsis, and we'll also go through some of the strategies for recognizing and diagnosing sepsis in the early stages so that our management is effective. will outline the current management approach as per surveillance campaign guidelines, and also discuss the principles of management of septic shock. And at the end, we'll lay down some recommendations that we can use in order for us to be able to implement in our settings. At this point, let me introduce Dr. Julian Chomba to take us through the first session, the first phase of this session. Thank you so much. Dr. Chomba, are you there?
Hey, good afternoon, Dr. Ndaba. I'm around.
Oh,
can you hear me?
Yes, we can hear you loud and clear. The floor is yours, madam. You can go ahead. Thank you.
Thank you very much. Greetings to everyone who's joined this webinar. We are pleased that you've actually joined us, and also humbled that I'm part of this webinar as a presenter. And obviously, like Dr. Ndaba said, we are discussing sepsis and septic shock, something that we come across as health workers in our various hospitals. And clearly, we can all testify to all the challenges that we encounter as we manage patients with sepsis. And as we start with the introduction, really the concept of understanding sepsis has evolved over time. And with the medical knowledge that has been coming up and improvement of tests and advancement of assessment of things, one thing still remains and is still acceptable and understood, that sepsis is a life-threatening medical condition whose prevalence and impact is underestimated in most clinical settings. And this is globally, and we still find most patients coming in sepsis, coming with so many challenges, and yet still underestimated in the settings. And sepsis has been defined as a syndromic response. So ideally, there must supposed to be infection that is supposed to be there. And then there's a host response to this, and it gives a spectrum of disease. So it's not one particular thing, it gives a spectrum of disease where some hosts who will have infections will only respond in a milder form, whilst others actually will respond in much severe forms, leading all the way to the pathway of death. And if sepsis is left untreated, as I said earlier, it's along a spectrum, then we are going to have complications that are going to come with it. Commonly, as we see them, we see patients coming who are septic, they come in septic shock, and we'll see a multi-organ failure. And ultimately, when all this is overwhelmed and unresolved, we actually see the patients dying because of sepsis. And it does really remain a very significant clinical problem and a major cause of mortality in ICUs, emergency departments, and high dependence unit. What therefore means is that early recognition and effective management of sepsis will actually improve the outcomes. We recognize early, we treat effectively, and ultimately we hope that we'll get this mortality lower than it is currently. Next slide, please. Next slide, please. Hello, can you hear me? Thank you. So what's the burden of sepsis? Of course, on people, on health, care workers, health systems, and globally. So it is still said that sepsis is actually a major healthcare problem. And in 2017, a study was actually made where they found 48.9, or rounding off to 49 million cases of sepsis, and 11 million of deaths were related to sepsis worldwide. This ultimately accounted for 20% of all global deaths. And as you can imagine, it's worldwide. Therefore, the study showed where much more of these septic related deaths or septic cases were. 85% of these global deaths or the cases that were studied in 2017 were from low and medium income countries. And of course, eventually in the studies, much more were related to reasons why we still had a higher percentage from low and medium income countries. But you can still see that 20% of all global deaths is quite significant, showing that it's still a burden from either the developed countries as well as from underdeveloped countries. And in 2020, WHO brought out an article that was discussing sepsis. And through this, it was noted actually that, as we said, being a spectrum of disease, even as patients respond to sepsis, you will have some patients that are actually going to recover from sepsis. But those that recover, 40% actually tend to be readmitted in hospital within a year of having had sepsis. And then others that would go with morbidities, would go with morbidities, 1/3 of that group will actually die within a year after experiencing sepsis. However, 1/6 of those that are actually affected suffer significant morbidity like cognitive impairments and organ problems. So some will end up in chronic renal failures, some will end up in chronic liver failures after they've actually had sepsis. What that entails is that whilst these other people are being readmitted, the burden is still much heavier on the health care system, but also globally on families, on individuals. You realize that when they have sepsis, it will have its own burden at various levels. And therefore, WHO recognized that sepsis was actually a global issue, and they came up with resolutions, most importantly, to improve prevention. So letting people be aware, or letting people seek healthcare much earlier before disease progression is worse. And obviously coming up with diagnostic tool, making sure that we quickly recognize, find that the patient has sepsis, and having clinical management of it. Next slide, please. Thank you. So with sepsis being recognized as a burden and how much it's actually affecting the numbers globally. So groups of clinical experts have been coming together to find ways of getting to find a proper definition of sepsis, all in a way of wanting to have everyone recognize it much earlier, and of course having prompt treatment. And in 1991, that's when the SARS criteria or SARS definition was actually made, that came up with how clinicians were supposed to recognize a patient who was actually having sepsis. And they defined this as body's response to a variety of several clinical insults characterized by the presence of 2 or more of temperature that's greater than 38 degrees or less than 36 degrees Celsius, a heart rate of greater than 91 beats per minute, respiratory rate of greater than 20 breaths per minute, a white cell count of greater than 12 or lower than 4 per liter, or if there were 10% of immature neutrophils. What that showed was that infection was going on white cell counts, mature white cell counts were overwhelmed. Therefore, immature cell counts were still being taken out so that they play a role in fighting the infection. And that is how SARS had given these 4 criteria. And they went ahead to define sepsis to be SARS, which are these criteria above, in the presence of infection. And within this definition, there was a subset of severe sepsis, where you have SARS, of course, in the presence of infection, but then it's associated with organ dysfunction. And then you'll have hypotension, which was defined to be systolic blood pressure of less than 90, or a reduction of greater than 40 millimeters of mercury from the patient's normal blood pressure in the absence of other causes of hypotension. So other causes could be if the patient has got a cardiac problem and they're having problems with the heart, they could be hypotensive, maybe arrhythmias can lead to hypotension. So everything ruled out, and the only reason we are seeing hypotension is because of the disease process that is going on. And then they went on to say organ hypoperfusion that was related with signs like lactic acidosis, oliguria, and acute attenuation. So all this was put in place to try to define what sepsis was, and that is how they were coming up with criteria. Other than severe sepsis, they still recognized that it was a spectrum, so some would come in septic shock, and this was defined as sepsis with hypotension despite adequate fluid resuscitation. So you'll have a patient realize they're hypotensive and fluid resuscitation is done, yet they don't get to respond, their MAP doesn't get to improve, and you end up using vasopressors. So that is how, or with all these criteria above, they came up with that. Multi-organ dysfunction syndrome was described as a state where dysfunction is seen in several organs. However, this definition fell out in the process because clinicians realized that actually this was quite broad. It was not so specific that this definition was only for the infective process. You could still have a patient who will have a higher heart rate, a patient who will have a higher respiratory rate, when actually it's not because of infection, but because of other things. And therefore, consensus kept on coming. Next slide, please. Next, thank you. And so still international consensus definitions still kept on coming. And from 1991, 1991 was called SARS-1, but there was also a SARS-2 10 years later, which still tried to expand in terms of the list of symptoms and signs that needed to be added for you to definitively come up with a sepsis diagnosis. But still, eventually, all this really did not bring out the definition that definitively said when a patient is in this way, then they're septic. In 2016, Sepsis 3 was actually published, and this was a general consensus where the definition now eliminated the requirement for the presence of systemic inflammatory response syndrome to define sepsis. And then severe sepsis as a definition as well was actually removed. And what was then used as a definition for severe sepsis is what is now a new definition of sepsis. However, there's a disclaimer to that, and authors guide that you still use the SARS criteria, and it should continue to add general diagnosis. So it's not like, no, the SARS is falling out of favor, then we don't use it. We'll still use it. It can still guide in us defining or identifying a patient that has sepsis. Next slide, please. So currently the definition of sepsis according to Sepsis 3 is that sepsis is a life-threatening organ dysfunction due to dysregulated host response to infection. So as previously was defined, infection still remains a common denominator. There's supposed to be the presence of infection, and then the host responds to this infection. But unfortunately, the response tends up to be dysregulated and leads to a life-threatening organ dysfunction, and much more other organs get to be affected. So in 2016, that was the publication of the definition of sepsis that we are currently using. And then organ dysfunction was defined as an acute change in total sequential organ failure assessment, which is a SOFA score of 2 points or greater secondary to infection. So there is supposed to be the presence of infection. Then we have a score that was being used that had 6 elements showing different organs and the progression of disease. So using those scores, which we'll see further, using those scores, if from the baseline of where the patient was in different organs, there's an increase in points or worsening of the organ functionality by 2 points of different places, then organ dysfunction was supposed to be added as the definition. As you define sepsis, then you see what else, what other organs are being affected. So what this means is that you will have a baseline of organ functionality. And then as you keep on seeing the patient or the progression of disease process, you see how organs are functioning. And if there's any increase in 2 points of either, then you are going to define that there is a organ dysfunction in any particular organ. Next slide, please. Septic shock then was defined by persisting hypotension requiring vasopressors to maintain a mean arterial pressure of 45 millimeters of mercury or higher, and the serum lactate levels greater than 2 millimoles per liter, despite adequate volume resuscitation. So the septic shock definition really still doesn't change from the SARS criteria. It still does recognize that you have persistent hypotension despite adequate resuscitation, despite adequate volume resuscitation. And a few of these patients will actually go to septic shock, and it's where you see the circulatory and metabolic abnormalities that is associated with increased mortality. And generally in practice, we see this, that patients who come who are septic and they become septic shock, they go into septic shock, actually, there's increase of mortality in these patients. Next slide, please. So generally, the causes of sepsis are all microbial elements. So you will have causative organisms that will be bacterial, that will be viral, that will be fungal, and that will be parasitic. So it's across the board. What that means is that when we are actually trying to find out or to make a follow-up of what is the likely organism or what is going on, we should have tests that will be broad enough to check for all these elements, as opposed to a general approach where we think bacterial is much more of the causative organism. So this gives a background that when we are trying to investigate patients, we try to look for the likelihood of fungal infection in this patient, what could predispose them, and we look for these elements, making sure that we isolate what would actually be causing sepsis in these patients. Next slide, please. So the common sources of infection, these are the percentages that have actually been aggregated from the so many research papers that have gone on. And generally respiratory source or origin gives a higher percentage, which is like 38%. And then we'll have things like catheter-related stream infection. It gave 2.3. What that means is that when we have patients with maybe PD catheters, or when we have patients with central line, we should be mindful that that will be a source of sepsis, and we take all preventive measures to reduce on transmission of infection. And then we will also have other devices, like if we have a patient who is ventilated, endotracheal tubes, urinary catheters, and all that, it is still accounts for 1.3%. Others like cellulitis, other breach of skin integrity gives a much higher percentage, like 11.3%. Therefore, when we have patients who are coming with sepsis, we're supposed to look for the likelihood or the common causes or sites of infections as we are actually taking care of them, so that we pick the site of infection and act appropriately. Next slide, please. So who's at risk of sepsis? Advanced age. So we actually, when it comes to age, we have the extreme age ranges. So we have the elderly and we have the very young. Commonly, they say the less than 5-year-olds are more predisposed to infection, but much more those ones that are less than 1 year. And obviously, this would be because of the building up of their immune system. Please forgive me, my dogs are giving a bad background. So it will be because of the mounting of the inflammatory responses that may not be as effective, and then you see them to be quite septic. We also see patients with chronic diseases, and those with chronic diseases with associated immune compromise, like in diabetics, like in patients with cancer and other immune suppressive states. The critically ill in ICU and HDUs are also predisposed to or at risk of infection. Remember, in HDUs and ICUs, we are using all these different devices. We are using the central line catheters, and from what we saw, all this will actually put these patients into risk of acquiring infection and leading to sepsis. In emergency conditions like diabetic emergencies, these patients will become very sick. They may come with diabetic foot, and that will also put them at risk. Skin ulceration, we all understand that the skin is a major barrier of infection from our internal environment to the external environment. Therefore, if there's breach in the skin integrity, then we'll expect patients to have a risk of acquiring infections and ultimately ending up into sepsis. And so is major surgery. And like I said earlier, invasive procedures will also predispose these patients to sepsis. What therefore means is that we look out for patients who are at risks of sepsis. We prevent. So if we are doing an invasive procedure, we make sure that we do it in the most sterile manner. And if we are attending to patients who have all placements of these catheters, we make sure that we take all precaution to minimize or prevent transmission of infection to these patients. Next slide, please. So the pathophysiology of sepsis, really, we are not going into the depth of understanding like we did when we all attended. We went through pathology lectures, but we want to appreciate that because the definition of sepsis is saying the immune response that becomes dysregulated, we need to understand with the background that with the background of inflammation that occurs. So I'm really not going into the depths of all those elements as in what they do, but generally the most understanding would be that normally when we have an invasion of microbials, the host response or the host defense mechanism is actually activated. And much more, as we say, the first defense team would be your neutrophils. And then in the tissues, we'll have the macrophages. And the body will try to make sure that it curbs that infection at a localized place, just at the site of infection. That's where all the inflammatory processes are going to occur. And the neutrophils, macrophages will try to localize that infection there. But unfortunately, in the process of doing this, the macrophages and the neutrophils they actually release the components that tend to obviously attack the microbials that invade the host, but also ultimately it may lead to cell death or injury to the cell, to the vessels. And when these hosts or these neutrophils and macrophages release the pro and anti-inflammatory cytokines, they will lead to processes of vasodilatations. If it's on the skin, we'll actually see that at the site of where the problem is or the infection is, we're going to see the redness as a sign of inflammation, and we feel or we touch that area, it's actually going to be warm. So those 5 signs of inflammation that we learned still happen wherever inflammatory processes are happening. With vasodilation, therefore, comes increased permeability as well. So vasodilation increases flow of blood to that particular site where infection is, and ultimately sends more neutrophils to go and help in the fight of an infection. But in the process as well, there's increased endothelial permeability, and not only neutrophils will go to the site of infection, but also you will find the release or the secretion of fluids that will go in particular organs. And in the process of all this, with the injury on the endothelium, there's activation of the coagulation pathways. So there's activation of the platelets, which will try to actually repair the damaged vessels, the damaged tissues. So when platelets are activated, it's in response to trying to repair the damaged vessels or the damaged tissues that has happened during the process of trying to stop these microbials to invade the place. Unfortunately, this normal physiological response tends to be overwhelmed during sepsis. Next slide, please. Next slide. So I'm getting much more on the lower part because much of the part is what I was trying to explain. Your microbials will bring in endotoxins, which will actually, the liposaccharides from these bacteria will bind to your macrophages, that is in the tissues. Macrophages are going to release tumor necrotic factors that ultimately will bring up a flare of cytokines. And eventually these cytokines are going to trigger things like the hypothalamus into that cyclooxygenase pathways. And we are going to have things like fever, tachycardia, and tachypnea. But on the other hand, with capillary endothelial injury capillary endothelial injury, you are going to have neutrophils that are going to migrate to that place. And obviously there's an injury that has happened on the capillaries, and therefore the platelets are going to aggregate so that fibrin is deposited there, and repairment of these vessels happen. But remember, we said it's a systemic, so it's not happening in one place, it's happening in several places. And we are saying there's dysregulation of host response. Therefore, the balance between the pro and anti-inflammatory mediators is breached. And you find that the platelet adherence or production is going to be overwhelmed. And at the end of the day, fibroinflammation is not going to happen. And therefore, patients are not going to be able to clot. And when they fail to clot, these are the signs we see in patients who end up having DIC. And of course, we are going to see ultimately patients presenting with DIC, or at times on the skin, they're going to have all those signs of petechiae because of the small thrombosis that is going on in the small vessels on the skin. But again, as the process is going on the vessels or in the vessels, you have the release of one of these mediators is nitrous oxide. And when it's synthesized, this is going to lead to vasodilatation. Remember, we spoke about vasodilatation. This is aiding that neutrophils go to the site of an infection. But unfortunately, this is going to reduce the volume. It's going to reduce the systemic vascular resistance. And ultimately, if there's reduced systemic vascular resistance, we are going to reduce the cardiac output. And therefore, we are going to hypoperfuse most of the organs in a patient with sepsis. And this will lead to cellular hypoxia because oxygen is not going to be delivered to these areas adequately. And when we have cellular hypoxia, we are going to have cell necrosis. And ultimately, we are going to have, from organ dysfunction, we are going to have organ failure because the organs are going to fail to actually happen. So in the simplest term, it's inflammatory processes happening not only at the site of infection, but because now this becomes systemic, it's happening in several organs that are away from the site of infection. And that's how come we end up seeing several organ dysfunction. Next slide, please. Next slide, please. So early recognition is key, and most of the screening tools are used to recognize sepsis. And of course, we'll go through different ones. And in keeping time, I'm trying to go through those very quickly so that we leave time to know how to get to manage the patients. Next slide, please. Next slide. So we still remain to our general ABC assessment. And with the ABC assessment, like we usually do it in practice, we'll see that as we go through this approach, we are likely to pick most of the complications that are coming with sepsis, most of the organs that are actually dysfunction. And when we pick this, we recognize them much earlier and we actually act appropriately. And of course, we still use the SARS criteria that I actually alluded to earlier. And we follow that, and it's said that the presence of 2 or more of these values indicate active inflammatory reaction. So when a patient comes and we have all these and we check 2 or more of these show that there's actually active inflammatory reaction that is going on. Unfortunately, not very specific for specific infective processes going on. Next slide, please. Next slide. And then we are also going to use our early warning score. So we can use the National Early Warning Score or the modified early warning scores. All these are just tools that we are going to use. As you can see from the screen, there are variables that are there and they give you a guide from 0 to 3. And depending on which end the patient is, you score the patient. And you see that patients who generally are on 0 of low risk, and then those that aggregate to 5 to 6 are of medium risk of sepsis or deterioration. If at all you have a patient who will have a red score in one parameter, take for example respiration, you have a 3, those ones are scored red, and you need to be more vigilant in trying to monitor them and trying to pick the signs. Those ones that score above 7 or above, they are at high risk, and we need to monitor and act appropriately. Next slide, please. Next slide. And then we have the sequential organ failure assessment. This had six to seven variables that were being used, of which there were the exam variables and the lab variables. So it goes up to a score of 4. And in each variable, you'll see that a patient definitely who will fall through to 4 score in each variable is likely going to have a poor prognosis of sepsis. And this eventually, because it needed the lab results, which we can appreciate that in most areas may not be available for us to use, definitely for us to say, okay, this is sepsis. Therefore, a quick SOFA score was made. Next slide, please, which reduced this down to 3 elements. That was talking more of, next slide, that was talking more of CNS involvement, which was just autoaugmentation, and of course the respiration and hypotension. And those patients that had 2 or 3 point scoring. So if you have a patient and they have autoaugmentation, this was from baseline, remember. You admit them and they were in a certain state and they tend to deteriorate, probably. They become unconscious and they're hypotensive by the definition of systolic blood pressure less than 100, then they score 2 points. And that indicated that they are actually at a high risk of poor outcome. So this score is actually showing the prognostic factor. It's a tool to help assess the prognosis, not necessarily making the diagnosis of sepsis. It's aiding in trying to see how you manage the patients. Those ones that were at 0 or 1 needed only, were at low risk and needed continued management as it is. What this whole thing means is that we need to recognize sepsis much earlier, and we can use different tools that will aid us to identify sepsis and ultimately manage patients so that we reduce the burden of sepsis in the healthcare system. Thank you very much. Thank you.
Thank you so much, Dr. Chomba. That was a very well presented session. Now we are going to transition on to the second part of our webinar, and this will be discussing management of sepsis and septic shock. I just want to quickly remind our participants that we've sent a couple of links which can give you access to more literature on the topic. So kindly visit our chat box and be able to download some of the literature from there. It's quite useful, and then at your own time, you can lead through for more understanding. So I'll invite Dr. Ziambo Masuzio to take us through the management of sepsis and septic shock.
Hello, everyone. Thank you very much for that, Dr. Spoka. So we're now going to go into management. Now that we know what sepsis is and the pathophysiology, now I think this will be much, much easier to understand. So when you're looking at the management of sepsis and septic shock, there are certain principles that you need to always remember. First of all, recognition. I'm sure Dr. Chomba has labored on how to recognize a septic patient and what are some of the things that you can do, the criteria you could use. And then the second thing that we do is resuscitation. And so in resuscitation, this will involve your oxygen therapy and you're trying to make the patient more hemodynamically stable. And then after that, this is done concurrently, aggressive monitoring of the patient, and then antibiotic therapy and source control. So we shall go through each one of them and see what's involved in each one. If we could have the next slide. So when you speak of when you talk about resuscitation, this is a rapid administering of emergency measures so that you can sustain life. So usually what happens in critical care, you assess the patient and you resuscitate. These occur concurrently. So now what we mean here is that when a patient presents to you in an ICU, you are not first going to assess, you find that the blood pressure is to the next thing, no. So what you're going to be doing is you're going to be assessing and resuscitating concurrently. And we all know that the best approach to resuscitating a patient is to prioritize your ABC. That's your airway, your breathing, and your circulation. And we know that the Surviving Sepsis campaign recommends resuscitation and treatment should begin immediately. So you need to start the treatment immediately you have the patient. So our next slide. So when you look at the airway, and breathing, so you make sure that the airway is patent, the patient is breathing, you assess those, you administer oxygen to the patient with the aim of keeping your saturations at least 95, above 95. And then now we know that hypoxia could be a feature of sepsis and can be due to various reasons such as hypoperfusion, toxemia from the metabolic rate, and due to respiratory failure. So you need to keep in mind that hypoxia could be multifactorial in these patients. Yes, the next slide, please. So once we are done with our airway, breathing, and circulation, and breathing, we go to our circulation. So as you are assessing for circulation, you're looking at your urine output, you're looking at your blood pressure, you're looking at your pulse, and you're looking at your capillary refill time. At that point, you need to make sure that you put in your large bore cannula and you collect your samples, and that's we'll look at these, and these include your different blood tests such as your full blood count, your cross match, your liver function test, your lactate, and your blood cultures. So at this point, once you've put in your large bore cannula, you collect your samples. In centers that have central lines, this would be preferred, but we just have to make sure that the central line should not delay our resuscitation, because central line sometimes, it depends in which hands that are putting in the central line. Some people might take long to put in. So you need to ensure that the central line does not delay your resuscitation. And you start your administration of your crystalloids at 30 mils per kg. This should be done at least in the first 3 hours of your resuscitation. So you want to make sure that you start your resuscitation. So you can see on our slides, we've put some recommendations which are in blue. Now, these are recommendations that are coming in from the Surviving Sepsis Guideline, the 2021, which is the latest one. Like Dr. Chomba has said, our latest Surviving Sepsis campaign is for 2021. And this suggests giving crystalloids at least 30 mils per kg. So you see that going forward, the slides have these blue recommendations, and these are recommendations from the Surviving Sepsis Guidelines. If we could have the next slide. So when do you start thinking about, when you've given your 30 mils per kg, when do you start thinking about your vasopressors, and what vasopressors are you going to use? Now, the patients that are indicated for vasopressors are those with septic shock. These are, like Dr. Chomba had alluded to, hypotension despite fluid therapy, or those with a lactate of greater than 2 without hypovolemia. So now these patients are in septic shock. You've given your fluids, they might respond a bit, but some might be non-responsive. So you want to use your vasopressors. Now, the vasopressor that is the aim of giving a vasopressor is to keep your mean arterial pressure at 65. There is no benefit really of getting a very high MAP. So you want to make your MAP at least 65. So now, what vasopressors can you use? So the first line, your first line vasopressor is noradrenaline. And so if your noradrenaline is the same as norepinephrine. And if this you do not have, you can use dopamine, which is your second line. Then you have your vasopressin. Now, I should be quick to mention that your vasopressin is not going to be used on its own. When you actually use vasopressin is when you're using noradrenaline, when you've reached your maximum dose for noradrenaline and you feel like the patient requires more vasopressin, then you can use vasopressin. Then if you don't have these, you can use adrenaline or angiotensin too. So going forward, we'll look at the dosages that we use in each of them. Maybe we could go to our next slide. So we'll start with our first line. Like we said, for septic shock, you use noradrenaline. Now, noradrenaline is a very potent vasoconstrictor through alpha-1 receptors. And if we remember, it acts through alpha-1 and beta-1 adrenergic receptors. So what will happen is it will cause your vasoconstriction, and the dosage is between 0.05 to 0.15 micrograms per kg per minute. Now I know that in different facilities, we might have syringe pumps that give us per hour. So you can do the mathematics to just change it to hourly, how you would give us per hour by multiplying by 60. Then if you reach a maximum and you feel that you are not reaching an adequate MAP, remember the MAP we had said was 65. If your MAP is not being achieved with your noradrenaline, you can then use vasopressin, which you can add on to your noradrenaline. Then, so in practice, usually your vasopressin is usually started when the dose of norepinephrine is in the range of 0.25 to 0.5 micrograms per kg per minute. And I totally understand. In the facility where I work, we don't have this vasopressin. So usually, if you are dealing in a low resource setting, you might not have vasopressin. Some facilities might have noradrenaline, but do not despair. If you do not have this one, you can go on to your second line drug, which you could use, which is dopamine. Could we? Next slide. Thank you. So dopamine in most facilities is usually available. Now, dopamine has got both alpha-1 and alpha-2 adrenergic receptor activity. So it's an agonist. Now, always remember that it will depend on the dosage that you're going to use for dopamine. If you use, your dosage is going to range between 2 to 20 micrograms per kg per minute. Now, the dose that you're going to use is going to be very important. If you use a low dose, what you're going to have is predominantly vasodilatation of your renal and mesenteric coronary beds. So and that's typically between 2 to 3. So usually below 5 micrograms, you're going to have renal and mesenteric coronary beds vasodilatation. When you increase your dose between 5 to 10, that's when you start having your beta effects. So you have an increase in your cardiac output, you have an increase in your heart rate, your contractility. But when you now go to a dose of 10 and above, that's when you start having alpha adrenergic effects, your arterial vasoconstriction and your elevation on your blood pressure. Now, this is very important because you might be using a low dose and thinking that it's not working, but it's always important to realize the dose that you are using with dopamine. The next slide. Then vasopressin. Vasopressin, we spoke about it when we were speaking about noradrenaline. So this is a vasoconstrictor, usually through V1 receptors in the smooth muscles, and it leads to an increase in your MAP. And usually we don't use this as a drug on its own. We usually add it to noradrenaline when you reach a maximum dose of noradrenaline, but your MAP is still low. And usually we use a fixed dose of 0.03 units per minute for the treatment of shock. Next slide. Yes. Then one that most of us are very familiar with, adrenaline. Now, adrenaline is very potent alpha and beta adrenergic agonist. And usually this is used when the patient is unresponsive to all the agents, one of last resort. But in some facilities, you find that this is the only vasopressor that's available. But this is something that you can still use. And the recommended dose is 0.05 to 2 mics per minute, per kg per minute, IV as an infusion. But always remember that when you're using adrenaline tends to give you these tachyarrhythmias, myocardial and splenic ischemia, and it also increases your systemic lactate concentration. Now, this is very important in the context that in some times when you're investigating a patient for sepsis, you might be looking at your lactate levels. Now, if you're using adrenaline, just keep in mind at the back of your mind that the levels of your lactate are also going to increase. So even when you're looking at your lactate, you always look at it in the context of the vasopressor that you're using. And the next slide. So we go on to the next thing, that antibiotic therapy. Now, one of the most effective interventions to reduce mortality is the appropriate use of antimicrobials. And according to the Surviving Sepsis guideline, these antimicrobials should be given at least within the first 1 hour of the recognition of sepsis. So this is very important. Like I said in the beginning, because this should be given in the first 1 hour, and if you get boggled down putting in central lines, you might not achieve this. And this is also important in survival of the patient. Now, it's always important that even as you are giving your antibiotics, it's important to get your microbiological cultures, such as your blood culture, before you start your antibiotics. As long as it does not delay your starting of the antimicrobial, you shouldn't spend too much time getting your bloods for cultures and forgetting the use of antibiotics. That's what this statement means. So if you can't get the blood cultures quickly enough, just start your antimicrobials. Now, those patients who are at high risk of methicillin-resistant Staph aureus, we recommend using empirical antibiotics with an MRSA coverage, okay? And even those patients who have multi-drug resistant organism, it's important to think of giving 2 antimicrobials with a gram-negative coverage for empiric treatment. Now, these are the exceptions. So if you think that the patient has a multi-drug resistant organism or they have MRSA, you need to pick your antibiotics that actually cover for that MRSA. Next. So this now gives a good summary of our 1 hour bundle of what we should be doing in the first 1 hour of recognizing that the patient has sepsis. The first thing we need to do is measure our lactate. Our lactate, these are bloods. After you put in you've collected your blood. By and large, 1 and 2 you do at the same time when you're putting in your IV line and you're collecting your bloods. You get your lactate. So you get your lactate, you get your blood cultures, and before you administer antibiotics. Then the other thing you start is your broad spectrum antibiotics. Always choose a broad spectrum antibiotic because at this point, we really don't know what the organism is. And so it's important to get an antibiotic that's broad spectrum. Then you start your IV fluids, you get a balanced fluid, a crystalloid for hypertension or lactate greater than 4, you start it at 30 mils per kg. And if you have to, you start a vasopressor in patients with a mean arterial pressure of less than 65 millimeters of mercury. You want to start your vasopressors like we have the vasopressors that we've gone through. The next slide. Okay, so these are some of the investigations that you would want to look at depending on your patient. So your sepsis screen, for instance, you're going to look at blood cultures, urine cultures, your CSF, your sputum, your swab, and your chest x-ray. So you're doing a septic screen. You want to find out where this infection is coming from and how widespread it is. And then you get your supportive tests such as your lactate, your ABGs. Some ICUs don't have ABGs, but if you have an ABG, an arterial blood machine in your ICU, please make sure that you get your pH, your bicarbonate, your oxygen, and your electrolytes, your kidney function tests, your full blood counts, your D-dimers, your cardiac enzymes, depending on how the patient presents. Then imaging, ECG, echo, these will give you an idea of the function of the heart. So your supportive investigation will truly depend on your patient that has come through, and these will guide what type of other investigations that you might want to get. The next slide. Okay, so now we've done all this. We've started the patient on antibiotics, we've started the patient on fluids. And so what are we looking at? How are we going to monitor our patients? Ideally, these patients, one of the things that we should take away is that most of these patients, after recognizing sepsis, these patients tend to do well in an ICU and an HDU. And according to the Surviving Sepsis campaign of 2021, they recommend that you get the patient to ICU at least within the first 6 hours. So what you're going to be doing is regular ABCD assessment. Now, it's important, you can see we've started regular. So these patients need to be monitored very frequently. So when you're looking at monitoring, you're looking at your AB, your airway and breathing in terms of your saturations, your respiratory rate. On your C, you're looking at your heart rate, your blood pressure, your capillary refill time. On D, you look at your Glasgow Coma Scale, your temperatures, E temperature, urine output, glucose. Now, these are important because it's an ongoing resuscitation. And so you want to see if your patient is responding to your intervention. If you are in a center where you can put up invasive hemodynamic monitoring, then this would be a very good way of real-time parameters, such as your arterial lines, your CVP lines. If you are able to do this, these will give you real-time parameters. Passive leg raise is very useful maneuver to assess fluid response. So now what happens with the passive leg raise is you're trying to move a patient from semi-inclined to fully or flat, and you raise the legs up. What you're expecting is an increase in your cardiac output. Now, this works very well to show whether a patient will be responsive to fluids. So when you raise the legs, it's almost like giving a bolus of about 250 mils of crystalloids. So what happens is that when you raise the legs, you're expecting your cardiac output to go up and your heart rate to go up. This is going to give you an idea as to whether when you give the patient fluids, they will respond. So this is a really good, a good maneuver to know how to do. Now, I know that in poor resource countries, it might not be very easy to find invasive monitoring. So, but fluid passive leg raise is something that we can all do by the bedside. Next slide. Yes. So now these are recommendations based on clinical experience. So if you look at the recommendations, there'll be weak recommendations with low quality evidence, but these are suggestions that are made within the paper of some of the things that we can do for our septic patients. So one of the things is using dynamic measurements to guide fluid resuscitation over physical examination or static parameters alone. For instance, static parameters like blood pressure on its own, but instead using things like passive leg raise, where you see an increase in the fluids, where you use a CVP, for instance, to measure your stroke volumes, your capillary wedge pressure, to measure your stroke volume and your cardiac output, measuring the pulse pressure variations, or using an echo. If you have somebody who in your hospital that knows how to do echo POCUS, they might guide you on whether we should be giving more fluids or not. Then the other thing that we could, the other suggestion is that should guide resuscitation is decrease in serum lactate in patients with elevated serum lactate over not using serum lactate. Now, this is just a suggestion. If you are in a center where you can measure your serum lactate, you can look at whether it's increasing or whether it's reducing with your resuscitation. Now, like I said, during acute resuscitation, your serum lactate level should be interpreted considering the clinical contexts and other used causes of elevated lactate. Now, serum lactate has been shown to show you the prognosis really, but even when it's reducing, does not really guarantee you that the patient is going to survive. But it's still a good way of seeing whether the patient is responding to your treatment. Now, for adults there's a suggestion that patients with septic shock using capillary refill time to guide resuscitation as an adjunct to other measures of perfusion. So it's also important to, as you resuscitate this patient, you see the capillary refill time. We know that the capillary refill time should be 3 seconds or below. So you can actually measure and see whether your resuscitation is working by seeing your capillary refill time. Next slide. Now, so we've done all this. We've started the patient on antibiotics. We've got our bloods. We're investigating. We've started the patient on antibiotics. Another thing that we should always remember is the source control. What is causing this sepsis? Sometimes it could be an abscess that needs debridement. So it forfeits the purpose of giving antibiotics and leaving the source intact. So it's always important to control the source. So you do an anatomic diagnosis of the infection that might require agent control. For instance, patients with sepsis, patients that have infected necrotic wounds, all those things should be done. You need to remove that infection so that you don't overwhelm the patient's system. You need to make sure that you've controlled the sources of infection, even as you give your antibiotics. And the source control should be achieved as soon as possible following your initial resuscitation. So if you have a patient who has come in and they are very sick and you know that it's due to an abscess, the most important thing you need to do is first resuscitate them. Don't just rush them to theater without adequate resuscitation. Always resuscitate first. After you resuscitate, then get the surgeon or whoever is responsible for cleaning that wound or draining that abscess to do so before, because that will help with management of the patient. Now, removal of intravenous access and other invasive devices as soon as possible. After these can be your other sources of infection. So it's always important that you're always checking these lines. You put in a central line, don't keep it in for a very long time. Usually, if you're going to stretch it within 5 to 7 days, you need to remove that line and reinsert another one because it will become a source of infection. And sometimes we tend to put in IV lines and forget about them. Those might be continuous sources of infection. So it's always important to look at these sources of infection. What could be causing more infection to this patient, and make sure that we always put in new lines whenever these lines become infected. Next slide. Now, when will you use a high flow therapy and ventilation in sepsis? When you have worsening respiratory failure in patients who develop and sepsis ARDS, acute respiratory distress syndrome. Now, we know that ARS could be a cause of ARDS. So you always have to be very careful with patients with worsening respiratory failure. Their saturations, you're increasing on your oxygen. But so these patients are patients who are good candidates to start on high flow nasal cannula. And usually this has been recommended as the first line before you go to non-invasive. So your NIV. So patients with low GCS, and unfortunately the patient's GCS is too low, you cannot put on high flow. You need to now decide on ventilation, putting the patient on a vent. So some of the things that will prompt you to put the patient on high flow are worsening respiratory failure and patients that are developing ARDS. And on low GCS, if the patient's GCS is low, is very low, these are patients that you might want to consider intubating and securing the airway. Next slide. So in summary, what are our takeaway points? We know that sepsis and septic shock are major clinical burdens world over. Now, this is a world over problem, and that's why, like Dr. Chomba said, it's something that has been, people have been trying to improve on how best we can manage these patients since 2004 to date. And there've been 5 sepsis campaign guidelines that have been changed over time. So this is something that is a clinical burden, and it's something that we should really understand. It's a major contributor to mortality in various clinical settings. However, it remains treatable and manageable when intervention is started very early. So that's why it's important for early recognition and aggressive treatment if we want our outcomes to be good. And if Dr. Spuka has put in a lot of resources in our chat box on the guidelines that Surviving Sepsis has put forward. in managing sepsis and septic shock. And when effectively used, there's a reduction in the burden of, in the sepsis burden. However, there is still more that needs to be done to increase the awareness among healthcare providers, because there's so many healthcare providers that are still not aware about sepsis. So I think that the onus is on us to continuously teach various health providers that we're working with on the importance of early recognition of sepsis and its treatment. Next slide. Yeah, like I've said, increase an awareness. We need to increase on the use of implementation of the sepsis guidelines in the management of our septic patient, and routine use of sepsis screening tools that Dr. Chomba has elaborated on to patients that are predisposed to developing sepsis. And also patients, from the studies, it has been shown that patients tend to do well in ICU, and but at the same time, prevention and treatment of patients in the sepsis-prone environments such as ICU, patients can come in for something else and end up with sepsis. So it's very important that in these places, there's an improvement in the sepsis surveillance. Thank you very much. And so those are our references. I would recommend that we take time and read through some of these references that we've put up. Thank you very much.
Thank you so much, Dr. Ziambo, for that very wonderful discussion. And thank you so much, Dr. Chomba, also for the earlier discussion we had. I think on behalf of the participant, I should mention that your discussion was very clear, and I think the take-home message also has been well conceived. So at this point, I would like to invite and open the floor and invite questions, clarifications, or any additional experiences that we may have with regard to sepsis and septic shock and how we manage it in our setting. The floor is open. Kindly raise your hand. And then in the absence of us not being able to recognize your hand early, kindly just unmute your microphone and then go ahead and speak. Yeah, so I've seen there are two hands already. Just before I allow the participants to start commenting, let me quickly recognize the presence on our platform of General Obashina from Nigeria, who is a very well recognized critical care physician globally. Thank you so much, sir, for your presence. And also quickly like to recognize Dr. Dati, also from Nigeria. These are recognized individuals in the field of anesthesia and critical care with a lot of contribution in various ways. So thank you so much for your presence, and we would really value your contribution. So let me quickly invite Kahalu from Zambia to just quickly make a comment or contribution, or indeed ask, and then after that, I'll invite other participants as well. Kahalu, kindly unmute and go ahead and speak.
Thank you very much, Doc. I think mine is a contribution. Yeah, I think it is very important and very cardinal to recognize sepsis early. And this can be done, like we have said, the ER, the ICU, these are places where we find sepsis, or maybe patients who get sepsis from. So it is very important that each hospital maybe develops a tool or adopts the tools that are already there, so that we can identify septic patients early and institute proper treatment early, get the cultures, and then check all those lactate as soon as possible. That way we'll be able to manage those and able to resuscitate patients in good time and save the lives that we could lose due to sepsis. Thank you.
Yeah, thank you so much, Kahalu, for that very important, indeed, contribution. I think it's something that we really need to emphasize in our clinical practice as we attend to these patients. So let me also quickly invite Nancy Kasongo. Just after Nancy, I'll invite Josie, and then Dr. Dati's hand is up already to go ahead and give a contribution. So Nancy, kindly unmute and then go ahead and speak.
Great. Thank you very much for such a wonderful presentation. My question is to the first presenter. I wanted to ask on the definition of septic shock, in that you said it was shock in the presence of sepsis and unresponsive to resuscitation with crystalloids. So in the case that the patient is septic and has shock and it responds to crystalloids, so then what kind of shock would it be? Like in this case, I always thought that if the shock was there and the patient was septic, that it was definitely septic shock. I would like a clarification on that.
Okay, thank you so much, Nancy. That's a very wonderful question. May I invite Dr. Chomba to shed some light, and then I'll also open the floor to other members of the panel to contribute to the floor. Thank you so much, Dr. Yes.
I'm so sorry. I kind of had intermittent internet here, so I really didn't get the actual question or context. I got parts of it. I know she asked about a patient being identified to be in septic shock, but then
yes,
they respond to crystalloids, and then I didn't get the other part, honestly.
Yeah. So her question was, like you've clearly said, this patient comes in and they are septic and then hypotensive, and then you give fluids, and then they respond hemodynamically to the fluid management. I think before you even proceed to use vasopressors or other interventions to improve your MAP. So her question is then, what type of sepsis is that, where you've given fluids and then initially hypotensive, and then they respond, they stabilize hemodynamically?
Well, I think then they'll still be septic, but then we are going to look for reasons why they were hypotensive. Could it be that there's a process of just being septic, they were dehydrated? Or could it be that they have maybe any other underlying condition, probably cardiac, and in the process of all that? But in this particular case, when they respond to fluids, we bring this volume back, then the effect of that, which was because of vasodilation, is counteracted by the increased volume. Or maybe it could be that they are starting to reverse the spectrum. So what it is it will guide us to define sepsis, but at the end of the day, we're still going to look for, is this progressing? Is this resolving? Or are there other reasons why this patient can have can be in shock? For example, is it just sepsis alone, or there are other things? So I think that's how I would take it. I don't know what others would say.
Yeah, thank you so much, Dr. Chomba. I think that's clearly that is exactly the point. So Dr. Chomba defined septic shock as shock or a state where, despite adequate volume replacement, the patient still remains hypotensive, or your MAC is very low, such that at this stage you will not give further fluids because you may end up overloading the patient. Remember, the problem in sepsis is vasodilatation. So your vessels are just open, and so your perfusion is low. Yeah, so you have to proceed to vasopressors. So in that case, when you resuscitate hypotension with sepsis, at that particular point, it's no longer septic shock. Unless you have ways of confirming hypoperfusion by measuring your lactate levels. Yeah. So, yeah, thank you so much for we really need to get these terms very, very clear. Dr. Hadati's hand is up to make a contribution. Dr. Dati, kindly unmute. Yeah, and
yes,
speak.
I've just done that. Can you hear me?
Yes, we can. Thank you.
Yes, thank you very much for the opportunity. I must say that this lecture is well delivered by these two experts. I can't remember the last time I had this kind of lecture, so clear and concise. Now, the way I see this issue of management of sepsis is the attitude. Now, most of the time, these patients are admitted into the ICU when it is almost too late. So we don't have the opportunity to even implement all this stepwise approach to managing this patient. Happily, I think the EECC network, I think, is seeking to address that practically. So what I think we should do, or we should be doing, that early recognition that is emphasized, and that has to do outside the ICU. I think this is very important. So if you implement that, we may begin to change this narrative, or this burden, because every day you see this patient coming in late, and those points where you have to recognize early are not being implemented. That is my contribution. Thank you very much.
Yeah, thank you so much, Dr. Dati, for that valuable experience, and indeed points of emphasis there. We should really emphasize on early recognition, and early recognition is likely to be more effective before the patient reaches the ICU. So we are talking about areas of first contact with our clinical areas. It could be your emergency room, it could be your general wards, so these are areas, I think, like Dr. Dati has mentioned, where we really need to emphasize. Yeah, thank you so much. I can't see any hands up already, but I would like to, as we wait for any hands up or contributions, I would like to go through our chat box and review some of the questions that have been asked. The first question is on why we use lactate-based intravenous fluids on a patient who could have increased lactate levels. Why do we use lactate-based fluids, yet our patient could have increased lactate levels? Dr. Sweetbet, would you like to give an attempt to respond to our participants, or indeed any panelists or participants that can contribute on this question before we proceed to the next one?
Hello. So thank you very much. I think that's a very, very good question. So our attempts, the beauty with the panels that they're very senior colleagues that might also guide. My understanding is that with when you look at Ringer's lactate, that's a base as opposed to an acid. It's a lactated ringers. It's a, how would I put it? It's a base. But when you look at these patients, they tend to have what is known as lactic acidosis. So these, the Hartmann solution doesn't really increase on your lactic acidosis, so to say, because what is in Ringer's lactate is a base and not an acid. That has always been my understanding of why we use Ringers. And Ringers, if you look at it compared to normal saline, you'll find that it's more a balanced fluid than and you realize that when you give a lot more normal saline, you're looking at hypochloremic acidosis also. So that's why we tend to give more Ringer's lactate as opposed to saline. That would be my understanding.
Okay, thank you so much, Dr. Ziambo. I think that contributes to the response that our participants might be anticipating. And also remember that lactate is a measure of hypoperfusion. It means your tissues, the cells are metabolizing anaerobically because you don't have, there's no oxygen available or there's reduced oxygen available at tissue level. So it's a marker of hypoperfusion. So when you measure lactate at the beginning of resuscitation, so it will give you an idea of the degree of perfusion at tissue level. So it becomes much more important when you want to interpret elevated lactate levels in context of how well your tissues are perfused, and not necessarily determining what kind of fluid, whether you're going to give Ringer's lactate or whether you're going to give normal saline to this patient. So it will be more helpful as a marker of hypoperfusion. And then if you're going to give Ringers again, you remember that, and then you're giving Ringers, and then remember also Dr. Ziambo talked about adrenaline use and how it elevates your lactate levels. So you might not be able to interpret your measured lactate levels accurately. And hence, most of the recommendations from the surviving sepsis guidelines on the measurement of lactate is not a high level recommendation. It's on the weaker side of recommendation, because it has to be used in the right context. So I think thank you so much, Dr. Ziambo. I think I would like to invite, there's a hand up, Unique Hamniela, kindly unmute your microphone and then go ahead and contribute as we wind up with the session. Hello, Unique, kindly unmute your microphone and go ahead and make a contribution. Okay, as we wait for Unique to come in, there's another question in the chat box. This question, the participant is asking to the role of procalcitonin in the management of sepsis and septic shock. What is the role of the measurement of procalcitonin in the management of septic shock? I think anyone from our panelists can jump in and make a comment.
Indaba.
Yes, Sweetbet. Yeah, thank you so much for coming through.
Yeah.
Please go ahead and make a contribution.
So basically, I wanted to add something from the actually on the previous question. What Zambo said, actually there are some studies looked at the fluid management in sepsis. Actually, lingalactate reduces mortality. We can share the links for some of the studies. So actually, lingalactate is superior to normal saline in those patients. So coming back to the PCT and clinical, which means MAP and lactate. These are the good marker, and then beta be used when you are talking about the septic shock. But when it comes to sepsis, if it's bacterial,
Dr. Sweetbet, we've lost you. Are you still there? Okay, I think we seem to have lost Dr. Sweetbet. Okay. Yeah, so as we wait for Dr. Sweetbet to come back and finish off his contribution, do we have anyone to comment on the role of procalcitonin?
Daba.
Oh, Dr. Sweetbet, welcome back.
Yeah, so I was using the Ngajima one. So I don't know where I ended up. I was talking about the procalcitonin, yeah?
Yes.
Okay.
Correct.
So for the PCT, it's mainly, it always goes with the bacterial infection. And it always tell you how your antibacterial are working or not. So we always prefer to do the serial ones. So maybe you do the first and the second, and see if it's going up, which means your antibiotics are doing well. If it's going up, which means you are not giving the right antibiotic for that organism. Of course, remember in the sepsis, we always prefer to do the culture before taking before giving the antibiotic. So you do a culture. As waiting for the result, you start the body antibiotic. So if you do the PCT and it's going up, which means that organism most likely is not covered with that antibiotic. But if it's going down, which means there's a chance whatever you are giving it's covering that organism. So it's mainly for the bacterial infection.
Yeah, I think, thank you so much, Dr. Sweetbet. I think that's very, very clear. It can never be more clearer than that. So thank you so much for that. I hope our participants has benefited from that response. Yeah, so I would go ahead and as we wait for hands and as we wind up the session, there's a question from one of our attendees. The question goes, what is the place of the use of dobutamine in the management of septic shock? Maybe I'll give this to Dr. Ziambo. What's the role? Is there a place for dobutamine in the management of septic shock?
Thank you very much, Dr. Spuka. Yes, if you have cardiac, you remember that your dobutamine has predominantly beta effects. So in patients with, if you're thinking that the patient also has got dysfunction, cardiac dysfunction, then you would use dobutamine because it's also good on cardiac function.
Yeah, thank you so much, Dr. Ziambo. I think that's precisely the response. And you remember that in sepsis, the problem is peripheral. You have peripheral vasodilatation, and in the presence of usually normal cardiac output, normal cardiac function. Unless you suspect that the patient has cardiac dysfunction, then you may want to reevaluate and then consider other inotropic options for management. Thank you so much, Dr. Ziambo. I still can't see any hands raised, so I'll read maybe the last two questions in our chat box before we conclude. So the next question is from Unique Hamniela. Unique asks, what measures can be put in place for early detection of sepsis, especially in poor hospital settings? Dr. Chomba, do we have any immediate response? What measures can we put in place for early detection of sepsis in low resource settings?
So I was actually just trying to type the response. Firstly, like the professor said, from where we're saying we need to, when he talked about the change of attitude. So firstly, really, we need to raise awareness among us, the healthcare providers, that we should all be aware of sepsis and know of its prevalence so that we can quickly recognize it and then act appropriately. And then also we can use simple scores like the ones we are seeing, a quick SOFA score, early warning scores. Those things we should have them either printed, attached, that immediately when we have a patient, we'll be able to see these signs that are very, very, very clinical, really. So as we are attending to this patient, we should be able to pick these things, and then they should guide us with obviously a highest index of suspicion that there's infection going on, and then we add up all the investigations that we have to do. But for us really to get to be and use all these tools and ultimately act appropriately, we need to be vigilant. We need to look out for sepsis. It shouldn't be at the end of it. That's when we're actually saying, oh, this patient was septic. And obviously, us living in low resource centers, we know that there's even a background of patients themselves having a lack of seeking healthcare much earlier when they are not well. So usually by the time they are coming to us, they are actually deteriorated. And therefore, we should be vigilant to pick, act much faster, and treat appropriately. Thank you.
Yeah, thank you so much, Dr. Chomba. And I think that's a very good response. And I hope that our participant has been able to benefit from that precise response. Then I would also like to draw the participants to the fact that this webinar is recorded and can be accessed on the Gradient platform, where you can actually log into the platform from the emails that you received, and then you'll be able to access this session. As we wind up, we're, I think, running out of time. I can't see any further hands that are raised. Let me invite General Obashina just to make a comment, an overall comment on the contribution, and if there's any specific areas that he would like to reinforce in this discussion. Dr. General Obashina, are you able to unmute your microphone and make a contribution, sir? The microphone is still muted, sir. We cannot hear you. Okay, it looks we are having audio issues with the general. So at this point, I would like to find out if there's any last comments from any panelists or indeed the participants before I invite Agredian to close. I'll give 10 seconds. If there's any contributions, any clarifications that can be quickly made as we wind up. General Bashina, please, if you are able to unmute your microphone, kindly feel free to log in and make a contribution. Okay, I thank you so much. I think in the absence of any further contributions. There's still, I think, 1 or 2 questions within the chat box that we've not been able to attend to. Please, some of the responses, or let me just allow Dr. Dati to just make a quick comment before we conclude.
Yeah, thank you. No, thank you very much. I said maybe you should look out for Professor Bibi Oshunaike if he's he's the president of the critical care site in Nigeria. If he has something to say, since General is unable to. Thank you.
Okay, oh, that's wonderful. Okay, Prof, kindly, if you're able to unmute your microphone, kindly go ahead and make a contribution. It's a pleasure to have you on the platform. Okay, we seem not to.
Okay.
Yeah, I think there's some audio challenges, but it's a pleasure to have you on the platform, sir. And unfortunately, we are not able to sort out the audio issues. Yeah, I think in the absence of any further contributions or clarifications, I would like to thank everyone who's made effort and time to join in this wonderful discussion. I hope you'll find this discussion very useful, and you'll be able to make use of the links to various literatures on sepsis and septic shock that we are shared. Also, feel free to interact with us in our various WhatsApp platform through which the adverts for this webinar was communicated. Feel free to continue the discussion on sepsis and various other topics in those social media platforms. Thank you so much, the participants, and indeed our panelists and presenters for this wonderful session. I would like at this point to invite Mariam from Gradient Health Systems to give us our closing remarks. Thank you so much. Mariam, the floor is yours.
Great. Thank you, Dr. Ndaba, and thank you to all our panelists and our participants. As Dr. Ndaba mentioned, you can interact with us at gradienthealth.org, where you will find the recording of this webinar as well as the webinars before it. You can also access them on our YouTube page. And I know that there are a lot of unanswered questions in the Q&A box, and apologies for running out of time, but if you would still like to get your questions answered, you can email us at customers@gradienthealth.org, and we can connect you with our presenters here on this discussion. Want to thank everyone for joining us for this presentation, as well as the presentations before, and we hope to see you at our next one. Please stay tuned for more information on the date of our last presentation for the year. And thank you again to all our panelists. I hope you all have a great day and evening, and I look forward to seeing you on our next webinar. Thank you.
Thank you so much, and bye for now.